Hey everyone, and welcome to this explainer on astigmatic retinoscopy. Today, we're really going to elevate our understanding from just rote mechanics to absolute clinical mastery. We aren't just here to memorize which dials to spin on a phoropter so you can pass your OCAPs. No, we're going to build a dynamic, intuitive mental model of exactly what is happening inside your patient's eye. By the end of our time together, you're going to know exactly where those focal lines are hiding, whether that's in the vitreous or way behind the globe, and exactly how to corral them right onto the retina. So let's dive right in and completely transform how you approach refraction. Here is our roadmap for today. We're going to cover 1. Collapsing the conoid of Sturm, 2. The two-step clinical method for retinoscopy, 3. The 5 types of astigmatism, 4. Plus versus minus cylinder techniques, 5. The patient accommodation board trap, and 6. Adjusting for working distance. But before we even get into the weeds, I want you to really think about this high-yield question. How do you perfectly collapse the conoid of Sturm without over-minusing your patient? Now, this isn't just some theoretical physics problem, right? This is a classic board trap and a literal everyday clinical challenge. Just take a second and think about the anatomy here. Keep this question in the back of your mind, because by the time we finish today, the answer is going to feel completely intuitive to you. All right, Section 1, Collapsing the Conoid of Sturm. So, astigmatism usually stems from the cornea having a steep axis and a flat axis. You can basically think of it as two built-in cylindrical error lenses. And because of this specific anatomy, light just doesn't focus to a single point. Instead, it forms what we call the conoid of Sturm, which features two very distinct focal lines. The entire goal of our clinical refraction, our ultimate objective here, is to use a spherocylindrical lens to physically manipulate these two rogue focal lines and collapse them into a single, perfectly crisp focal point right on the retina. That's the whole game. Moving right along, Section 2, Retinoscopy, two-step clinical method. Retinoscopy is brilliant because it simplifies this really complex optical problem into an elegant two-step algorithm. Step 1, we use sphere power to relocate just one of the focal lines, typically the anterior one, directly onto the retina. Then Step 2, we use cylinder power to move the other focal line onto the retina as well. Once both lines hit the retina at the exact same time, the conoid is collapsed. Boom, astigmatism corrected. It's really that simple. Now, here is a mental model I literally want you to burn into your memory right now. A spherical corrective lens moves the entire conoid together. A minus sphere pushes the whole conoid back, deeper into the eye or even behind it. A plus sphere, on the other hand, pulls the whole conoid forward toward the cornea. Why does it do that? Well, because a spherical lens is essentially two cylindrical lenses oriented 90 degrees apart, so it affects both focal lines equally. Cylinder, on the other hand, only moves one focal line, while leaving the other completely anchored in place. Minus pushes, plus pulls. For sure, burn this into your memory. Okay, Section 3, the 5 types of astigmatism. Look at this table and really try to visualize the globe as we go through these. There are basically 5 possible anatomical configurations here. In compound myopic, both focal lines are just floating up there in the vitreous. In simple myopic, one is in the vitreous and the other is already parked on the retina. In mixed astigmatism, the retina is literally sandwiched between them, so you've got one line in the vitreous, one behind the eye. In simple hyperopic, one is on the retina, the other is behind the eye. And finally, in compound hyperopic, both focal lines are falling completely behind the globe. Now listen up and pay close attention to this, because this right here is a massive OCAP pearl and a classic board trap. Do not confuse this. The circle of least confusion does absolutely not need to be exactly on the retina for it to be mixed astigmatism. For an eye to have mixed astigmatism, one focal line just has to be in the vitreous and one has to be behind the eye. Period. End of story. So many residents fall for the trap of thinking the dioptric midpoint between those two lines has to fall perfectly on the retina. It doesn't. As long as the retina is anywhere between the two focal lines, it's mixed astigmatism. All right, Section 4, plus versus minus cylinder techniques. Remember our golden rule from earlier? Plus pulls, minus pushes. So if you're refracting in plus cylinder, your cylinder can only pull a focal line forward. Therefore, because plus side pulls, all roads must lead to simple hyperopic astigmatism before you add your cylinder. You absolutely must leave the uncorrected focal line behind the retina. Conversely, because minus psi pushes, all roads must lead to simple myopic astigmatism. You have to leave the uncorrected focal line in front of the retina before adding minus cylinder to push it back. Which brings us to a really vital clinical question. Why do so many experienced clinicians contend that minus cylinder phospters are physiologically superior to plus cylinder phospters as refractive tools? Just think about that for a second. What actually happens biologically if a focal line sits behind the retina? And that leads us perfectly into Section 5, the Patient Accommodation Board Trap. Here's the absolute biological reality of the situation. Anytime a focal point or a focal line is located behind the retina, the patient's ciliary muscle is going to kick in. The lens will accommodate and subconsciously pull that image forward on its own to clear up the vision. But here's the problem. If the patient is supplying their own plus power through accommodation, you are going to supply too little plus power from the phoropter. You will end up over-minusing the patient every single time. Minus cylinder retinoscopy prevents this entirely. Because minus cell requires you to park the focal lines in the vitreous, so anterior to the retina, it naturally suppresses the patient's ciliary muscle. They literally cannot accommodate to push an image backward. In fact, for you PGY3s out there, here is an advanced clinical secret. You can actually use this alternative, board-tested strategy to completely circumvent the accommodation trap, even if you're forced to use plus cylinder. Instead of starting with simple hyperopic astigmatism, use your sphere to put both focal lines into the vitreous. Then, use plus cylinder to pull the deeper posterior line forward until it hits the anterior line, effectively collapsing the conoid into a single dot right there inside the vitreous. Finally, you just use minus sphere to push that single focal point backward until it rests perfectly on the retina. It's honestly a brilliant way to keep all the optical action entirely inside the vitreous, suppressing accommodation the whole time. All right, final stretch, Section 6, Adjusting for Working Distance. Here is the physical optics reality, and let me tell you, this is such a common pitfall for first-year residents. The endpoint of retinoscopy just means the focal point is on the retina relative to your retinoscope. The far point of the patient's eye is currently sitting exactly at the peephole of your scope. It is not at optical infinity. If you just take those lenses and prescribe them as is, your patient is going to be artificially myopic. They will literally only see clearly at arm's length, which is not great for driving. To give the patient clear distance vision, you have to move that far point from your peephole all the way out to infinity. You do this by taking your physical working distance, converting it into diopters, and just subtracting it right from your sphere. Since working distance is dictated by your arm length, a typical or maybe slightly shorter retinoscopist will have a working distance that equates to about 1.5 diopters. On the phoropter, that's 6 clicks of minus sphere. Now, if you're particularly tall, you might only subtract 1.0 diopter, which is 4 clicks. I need you to write this OCAP Pearl down in huge, bold letters. Always subtract your working distance from the final retinoscopy sphere. If you forget this step, you fail the clinical refraction and you're absolutely going to get the board question wrong. It is the mandatory bridge between the artificial optics of the exam room and the actual visual needs of your patient in the real world. So, as we wrap up this explainer, I'm going to leave you with this final challenge. Tomorrow in clinic, when you sit down behind that phoropter, are you going to rely on rote memorization, or are you going to actively visualize the anatomy we just talked about? To truly master this, you need to visualize the cornea, collapse those lines with your sphere and cile, suppress that ciliary muscle with minus cile, and never forget to subtract your working distance. Keep this whole framework in mind, and I promise you, you will absolutely dominate your next refraction.